Hello, my name is Sean Richardson, and I am proud to present my final project for the D&P discipline at Maryville University. The title of my project is, Will Increasing a Patient's Weekly Walking Minutes Decrease a Patient's Blood Pressure? First, I would like to thank all those who supported and encouraged me throughout this process, those including my committee, Dr. Tara Harris, Dr. Maria Snell, and Dr. Brittany Toledo, my community chair. The background and significance of my project surrounds hypertension and its risk factor for other diseases. Hypertension is a manageable disease process that, when left untreated, can lead to further complications. These complications include cardiovascular disease or stroke, and there are many treatment options for hypertension, some being medications, other being lifestyle modifications. My phenomenon of interest for this project was looking at exercise to manage blood pressure in adult patients with a known diagnosis of hypertension. The purpose statement for my project goes as follows. In adult patients 18 to 65 years old with a known diagnosis of hypertension, will implementing 30 minutes of walking 5 days a week decrease the patient's blood pressure over 8 weeks? So I reviewed many different articles and literature for this project. There are three themes that stuck out to me throughout all the literature that I reviewed. They are exercise, hypertension, and lower blood pressure. So the goal of my project was to use exercise for patients with hypertension to lower their blood pressure. So it is very encouraging when I was doing the review of literature to see all three of these themes throughout what I was reviewing. For exercise, it was shown in the literature that exercise is a vital intervention for lowering blood pressure. Throughout the literature, there were different forms of exercise that were used. Some literature, like my project, used walking as the main form of exercise. Others used aerobic exercises, and others used resistance training. There was also many differences in the literature with the amount of exercise completed per studies. Some studies it was 15 minutes, some studies it was 30 minutes, some studies it was 3 days a week, some 5 days a week, some started at 3, went to 5, and ended at 7 days a week. And some differed in the total length of the study, anywhere from 1 month, 2 months, 3 months, 6 months. For my project, I decided to use walking as the main form of exercise. I decided to use 30 minutes a day as the time limit, 5 days a week for 8 weeks. That would be the total amount of exercise for my particular study. The second theme in the literature was hypertension. A few of the articles that I read showed that between 2017 and 2018, 50% of American adults had hypertension. Hypertension is a preventable disease, and it is very manageable. Still, nearly half the adult population in America in those time periods were diagnosed with hypertension. As I mentioned before, and literature supports that hypertension is a risk factor for other diseases, cardiovascular disease, heart attack, stroke, things like that. One thing I found in the literature was that there were many differences in what the criteria for hypertension was. Some 130 over 90 was greater than 130 over 90 was a diagnosis of hypertension. Other literature, it had to be greater than 140 over 90 to be diagnosed with hypertension. For my patients, they are patients with a known diagnosis of hypertension, meaning I didn't newly diagnose, nor did the nurse practitioner who helped with the study newly diagnose patients when they were entered into the study. These patients already had to have a known diagnosis of hypertension. The final theme was lower blood pressure. This is the overall goal of the D&P project, is to use walking as an intervention to help patients lower blood pressure. A lot of the literature I showed, almost every article except one, showed that walking as an intervention or exercise as an intervention was able to help lower patients' blood pressure. One study did show there was little to no change in blood pressures after the exercise intervention, but they attributed that to the intervention not being as long as it should be, or participants not exercising as much as they needed to. The theoretical framework that I focus on was the health belief model by Becker. There are 3 parts of this model. They are understanding the risk of the disease, the belief that participating in healthcare interventions can lead to improvements, and understanding the process. Along with the 3 parts, there are 3 forms of motivation. There's perceived susceptibility, meaning patients will be motivated to prevent illness. There's perceived severity. This is patients or participants will be motivated to prevent their illness from worsening, and there's perceived benefit, motivation to receive improved results. So how does this theoretical framework fit into the D&P project that I proposed? Well, through the health belief models, participants can use these three forms of motivations to help encourage them to participate in the project. Now, perceived susceptibility doesn't really fit in as these patients already have hypertension, but perceived severity and benefit do. Patients who believe that by participating in this 8-week trial will decrease their risks or provide them with benefits such as lowering their blood pressure will be more motivated to complete the trial compared to those who don't have this belief that they can get better. Believing that this intervention may lower their blood pressure also encourages patients to get involved as well as to keep going throughout the process. Walking 30 minutes a day, 5 days a week for 8 weeks is not an easy task, especially when inclusion criteria included anyone who wasn't currently on an exercise regimen regularly. So these are people that maybe they exercise every once in a while, but they don't do it consistently. Now they're being asked to walk 30 minutes continually a day, 5 days a week for 8 weeks. That is not an easy task for some people to be motivated to do so. But through the health belief model, motivation is there that they can get better or they can prevent these risk factors due to their hypertension. So here's the methods and design of my study. Recruitment. I recruited patients at a primary care center known as the Center for Medicine. These were 18 to 65-year-olds with a known diagnosis of hypertension. These participants currently did not have exercise programs or did not exercise consistently. Other inclusion and exclusion criteria included that patients had to be able to walk, they had to be able to physically maintain all that is required for this study. They couldn't be put on a new medication within the last 30 days because then we wouldn't be able to tell, is it the new medication that's lowering their blood pressure or is it the exercise? And they couldn't be started on a medication within the time that the intervention is going on. Once again, we didn't want medications affecting the results of the study. The design of the study went as this. On the first day that participants were recruited, they would have their blood pressure measured. This recruitment took place on a Thursday and a Friday of 1 week and then all of the next week. If participants had their blood pressure recorded initially on the Thursday and Friday of the first period of recruitment, they would start the 8-week intervention that Monday. They would walk 30 minutes a day, 5 days a week for 8 weeks. And then after the 8-week period, there was open office hours for those who completed the intervention to come in and have their blood pressure remeasured. We were looking at the differences between the average blood pressure post-test versus the pre-test or pre-intervention average blood pressures, trying to see if pre-intervention averages lowered as a result of the study. So here is my sample size where you can see the demographics of everyone that was involved in the study. Like I said, this was adults only. These were participants between the ages of 18 to 65 years old, and they had to have a known diagnosis of hypertension. After speaking with Dr. Powles, a Maryville statistician, it was determined that 42 participants were needed for this study. I was able to recruit 50 to make sure that I had plenty if anyone dropped out. 7 participants did drop out. They either did not start the study after they said they would, or after a couple of weeks they said that they didn't want to do it. There was a few participants that didn't show up at the end when we had to have their blood pressure remeasured. But 43 participants had their initial blood pressure measured, completed the 8-week intervention, and had their blood pressure remeasured. Of the 43, 14 were female, which is 33% of the population. The other 29 participants were male, 67% of the population. Of those between the ages of 18 and 30, only 1 participant was in that age group, making up 2% of the population. 14 were between the ages of 31 and 50, making 33% of the population, and the remaining 28 were between the ages of 51 and 65, making up 65% of the population. Below, you can see 2 graphs that show the gender and the ages and how it breaks up into percentages for this sample size. Data analysis. So, for this type of study, there were 2 tests run, the Shapiro-Wilks and the paired t-test. The Shapiro-Wilks test is one that looks at the data and makes sure that it doesn't violate the assumption of normality. It wants to look to make sure that all the data in the specific groups measured were distributed normally. The other was the paired t-test. A paired t-test is a great test for looking at pre-test or pre-intervention data versus post-test or post-intervention data and determining if the changes in data are statistically significant. Due to the project's design, where it was pre-intervention blood pressures, both systolic and diastolic, were measured, and post-intervention blood pressures, both systolic and diastolic, were measured, the paired t-test was the perfect one. So we could take the average of the pre-test systolic blood pressure, the average of the post-test systolic blood pressure, and look to see if, one, there was a decrease in the average, and two, if it was statistically significant. The same thing with the paired t-test could be done for the pre-test diastolic blood pressure and the post-test diastolic blood pressure. So I worked with statistician Dr. Powell to determine the best test to run for my project, and this is what we determined would be the best. So these are the results of my project. The results section is going to be broken down into the normality test, the Shapiro-Wilks, the differences in blood pressures, and the paired t-test. So it's easy to understand how all the data breaks down and what it means for the project. So the first test that was run was the Shapiro-Wilks test, which tests for normality. If you look at the chart below, you can see all four of our intervention columns: pre-test systolic, post-test systolic, pre-test diastolic, post-test diastolic blood pressures. So when the test was run, in order for it not to violate the assumption of normality, the p-value had to be greater than 0.05. For my data, 3 of the 4 data sets came back not violating the assumption of normality. This is the pre-test systolic blood pressure, the post-test systolic blood pressure, and the post-test diastolic blood pressure. That means that the data is distributed in a way that can be assumed as normal. One data set, unfortunately, the pre-intervention diastolic blood pressure, did violate the assumption of normality. It had a p-value of 0.046, which is less than 0.05. Luckily, after talking to the statistician Dr. Powell, we determined that due to the robustity of the paired t-test, as well as the strength of the sample size, that this violation should not affect the data and that paired t-test would still be the appropriate test for my study. The next part of the results section is the changes in blood pressure. So, systolic blood pressure. The pre-intervention group, if you look at the chart on the left, had an average blood pressure of 142.86. The post-intervention systolic blood pressure had an average blood pressure of 139.74. This shows that from pre-intervention to post-intervention, the average blood pressure for my 43 participants decreased by 3.116 points. That was the goal of the study. We wanted to see a decrease from pre-intervention to post-intervention. So we were happy with this decrease of 3.116 points. Similarly, the diastolic blood pressure also decreased. The average blood pressure for the pre-intervention group was 76.28. It decreased by 1.88 points from pre to post-intervention, with a post-intervention average blood pressure of 74.40. You can see this on the chart on the right below as well. That means that the study showed that blood pressure for both the systolic and the diastolic groups decreased from pre to post-intervention. That means that the goal of the study was met in that we wanted to see this decrease. The final result is the statistical significance. This is where the paired t-test comes in. Not only do we want to see this decrease in blood pressure, but we also want our results to be statistically significant. The change in average blood pressure by 3.116 points from pre to post intervention was statistically significant. It needed to have a p-value of less than 0.05. If you look at the chart below on the left-hand side, right here, you can see that the p-value was less than 0.01, meaning that this was statistically significant. Similarly, the diastolic blood pressure's decrease of 1.88 was also shown to be statistically significant with a p-value of less than 0.05. Also, if you look at the right chart, you can see that it was less than 0.001. showing the statistical significance of the project. So not only did the project achieve its goal to use walking as an intervention to lower blood pressure, but its data also came back statistically significant. There were a few limitations for this study, one being the number of participants. Though 43 participants was adequate as it met the goal of 42 participants, the more participants, the more the data can be refined to determine how much walking truly affects blood pressure. The more people you have participating in the study, the more data points you have to run these tests on. Another limitation was the lack of ability to monitor each patient's walking sessions. There were 43 people who were walking 5 days a week for 8 weeks. Unfortunately, I, as a student researcher, could not watch all 43 people walk 5 days a week for 8 weeks. So, future studies could improve upon this by finding a way to monitor patients walking. There was a lot of trust that had to go in that made sure that these patients actually completed the interventions that they said that they were completing. So in future studies, this limitation could be avoided if there was a way to monitor each patient's walking session so you can actually truly see that they are doing exactly as the study outlines. Another limitation was focusing on time and not distance. Now, some people can walk 30 minutes consistently and they can walk a long distance. Other people walk slower or can't walk as far. So the study doesn't really differentiate between, okay, who walked further in 30 minutes? Does distance of walking affect blood pressure? Is it solely the amount of time spent walking? Other studies could look at changing the amount of time from walking 30 minutes 5 days a week to maybe walking 1 mile a day 5 days a week to see if distance or amount of time walking plays more of an effect on blood pressure. The other is sustainability. Not every person, unfortunately, can walk 5 days a week every single week. Some of the studies, as I mentioned earlier, only had participants walking 3 days a week. Some had them walking as much as 7 days a week, which doesn't sustainable. Future studies can improve upon this by changing the amount of days that patients walk. Maybe do a study on 3 days of walking a week, and if it shows positive results on lower blood pressure, that's an easier goal for patients to do. 3 days a week is a lot easier than 5 days a week. Or starting patients off like one study did, walking 3 days a week, then 5 days a week, then 7 days a week, or walking 15 minutes a day, 20 minutes a day, then 30 minutes a day. Giving patients who aren't able to complete the study demands that this one was more of an opportunity to improve their blood pressure and start slow and improve each week. These studies could be beneficial, and it could tell people, hey, yes, you can't walk 5 days a week, 30 minutes. Okay, how about you start with 5 minutes a day, 3 days a week, 15 minutes a day, 3 days a week, and then go up from there, as it's going to have, hopefully, positive benefits on blood pressure. So, as a result of my project, walking was a statistically significant intervention for lowering blood pressure. Both average systolic and diastolic blood pressure decreased. Walking is something that can easily be implemented into everyone's daily life. Yes, I said it's not sustainable for some people to walk 5 days a week for 8 weeks, but people can start somewhere, going on a 5-minute walk. As I mentioned, 10-minute walk. It's cost effective to walk. Yes, you need to buy shoes and appropriate clothes, but besides that, you can go walk your neighborhood. You can walk inside your house. If you have a gym membership, you can walk on the treadmill. Walking is a cost-effective measure to lowering blood pressure. As well as education on walking is also cost-effective. Providers, nurses, patients can easily be educated on the benefits of walking as an intervention for lowering blood pressure. Another benefit of walking is that there are patients who refuse to take medications. There are patients who do not trust medications, do not like the way medications feel, and let their blood pressure go untreated. This provides providers with an alternate option for those patients who don't want to take medications to try something to help lower their blood pressure. If they don't want to be on a beta blocker because it makes them feel tired, then okay, try walking. Try doing lifestyle modifications such as exercise to improve your blood pressure. So, as I mentioned a little bit above, the implication for practice. As providers, we can encourage patients to implement walking into their daily lives. If they can't walk 30 minutes a day, 10 minutes a day every single day. 30 minutes a day, 3 days a week. Provide them with different options where they can start somewhere, but encourage them to maybe get up to 30 minutes 5 days a week. It can be added to their treatment plan as well. Patients can be on medication and go for walks. They can work together to help lower their blood pressures. And as I mentioned before, it's an alternative intervention for those who don't want to take medication. Rather than those people just doing nothing and just accepting that they have hypertension or trying to encourage them to change their diet, walking can be encouraged and can give them something they can do if they don't want to do the other intervention that the provider is prescribing for them. So in conclusion, as I mentioned, my project showed that walking was beneficial for lowering both the average systolic and diastolic blood pressure. The data was statistically significant to show that it mattered. Primary care offices can encourage patients to walk. They can use this study to encourage them to walk 30 minutes a day to 5 days a week to improve their blood pressure. As a future provider myself, I look forward to getting to encourage alternative methods to managing hypertension other than medications such as walking. I look forward to encourage my patients on lifestyle modifications to improve their health, especially for those who don't want to take medications. And as I said, further research still can be conducted on this topic. Different studies can change the amount of exercise a day, the amount of days a week, the amount of weeks that the intervention lasts, the different types of exercise, starting slow and increasing. All these different studies can be conducted to further understand the effects of walking on blood pressure. And I'm thankful for my time in this DNP course, as I've learned so much that I can take into my future practice. As a future provider, I will use the skills that I learned throughout this DNP program to not influence only my decision making, my patient care plans, but also to encourage me to continue learning evidence-based practice to improve the quality of life of my patients. If there are any questions, now would be the time for them. And here are all the references for my DNP project. Thank you.